Thank you, doctors, for the wonderful presentation. So, moving on to our next session, inflammation and diabetes. Let me welcome Dr. CBNS, Professor of Medicine, Medical College, Trivandrum, and Dr. Sabir Rasheed, Organizing Chairman, Diabetes Today 2020. Over to you.
Sir, you can start, sir, please.
We will go on to the next session. Very interesting topics are there. The first speaker is Dr. Aravinda Jagadeesha. He will be discussing about inflammation and diabetes, the missing link. Inflammation is being linked with many non-infectious conditions like diabetes, coronary artery disease, and all those things. Now we will listen to Dr. Aravinda Jagadeesh, who is a speaker in various national and international forums. He is a senior consultant diabetologist, Dr. Aravind Diabetic Center, Bangalore. He is the president of the Karnataka chapter of the prestigious RSSDI. He was bestowed with Bangalore's highest civilian award. He is a winner of Times Healthcare Excellency Award also. Over to you, sir.
First of all, good morning, everybody. Thanks, Dr. Sabir, for inviting me for this wonderfully organized virtual conference. However, we always love to come to Trivandrum, but this time because of this corona pandemic, so this is a well-organized virtual conference. Congratulations for that. Today, my topic is on inflammation and type 2 diabetes, a unique connection. So as we all know, we have like ominous octet, that is 8 reasons for the pathophysiology of diabetes. And as the days going on, we are coming to know more and more of diabetes. I'm sure in coming days, it will be dirty dozen. Means 12 reasons for the pathogenesis of diabetes. So one of the important reason is diabetes is considered to be considered as an inflammatory disease as well. So today this session will discuss about this inflammatory aspect of diabetes. Me, Faraz, and Dr. Unni will be discussing about the 3 important topics about diabetes and inflammation. First of all, greetings from Bangalore. If you take inflammation, I'll go through the basics, certain aspects of basics of inflammation, so that it should be a revision for all of us. So it is a part of inflammation is a part of complex biological response of body tissues to harmful stimuli, such as pathogens, damaged cells, or irritants, and is a protective response involving immune cells, blood vessels, and molecular mediators. We all know the features of inflammation are heat, pain, redness, swelling, and loss of function. This is what we learned in our basic MBBS days. So what is the difference between acute versus chronic inflammation? You can see acute, what causes it. Acute inflammation like antigens such as bacteria, virus, trauma. Chronic inflammation is the unresolved acute inflammation. Continued presence of the antigen causes the chronic inflammation. What cells are involved in the response to the causative agents like polymorphonuclears, mononuclear cells, macrophages? Chronic inflammation, monocytes, macrophages, lymphocytes, and plasma cells. What mediators are released from that causes the signs and symptoms of inflammation? In acute inflammation, it is the vasoactive amines like histamine, bradykinin. In chronic inflammation, it is the cytokines, growth factors, ROS, and hydrolytic enzyme. When does this inflammatory response first appear? In acute inflammation, it is an immediate onset. In the chronic, it is a delayed onset. How long does this response last? Several days. In acute inflammation, chronic inflammation, it lasts long time, like it is months to years. So after the response, what happens to the tissue? Healing occurs once the inflammation is resolved. And in chronic inflammation, it leads to tissue destruction. I'm sure all of you know about this. Just a recollection of our knowledge. Chronic inflammation, principal link to cardiometabolic disorder. If you see, they take this inflammation, it is involved in so many diseases like atherosclerosis, metabolic syndrome, pre-diabetes, as well as diabetes. So what happens in chronic inflammation? What is the molecular mechanisms? You can see this, all the TNF alpha, interleukin 1 beta, PF, TGF beta, PKC, arachidonic acid. all leads to the activation of endosomal NADPH oxidase, leading on to ROS generation and activation of NAFKB, leading on to inflammation. This eventually leads to the development of atherosclerosis, diabetes, and metabolic syndrome. That is where the inflammation plays a role in the pathogenesis of diabetes. If you see earlier this slide, earlier onset of type 2 diabetes in Indians, if you see this two studies, that is cure study and NUDS study, in Indians we are seeing a type 2 diabetes onset a bit early compared to Caucasian. This is what this study says. So I'm sure most of you all seeing in your city that diabetes is coming, type 2 diabetes especially, is coming at an age of 25 years. In my city in Bangalore, more whereas more it is more of software engineers are there, because of a lot of stress and a lot of junk foods and all those things are happening. We are seeing a type 2 diabetes at an younger age group around 25 to 30 years. The predilection of type 2 diabetes among Indians, you see Asian Indians 2 to 3-fold higher prevalence of insulin resistance compared to ethnic groups. Diabetes develops at an younger age in Indians, that is at least a decade or two earlier than the European. This is the most worrying things for our Indians. We have to seriously address this issue from doctor level as well as the government level. We have to address these issues. Migrant Indians have much higher prevalence of CAD and CAD mortality rates compared to the host population in US. Indians develop CAD at least a decade earlier. So all this is an important aspect to be considered in our patients. This is the famous Professor Yagnik's chart, that is the thin fat Indian. So Indian thin fat Indian, low BMI and high central obesity. You can see the Professor Yagnik sitting with the Caucasian. Both of their body mass index was 22.3. But if you see Professor Agnik's body fat was 21.2% compared to the Caucasian, that is 9.1%. What does it say? The Indians are leanly, what do you say, is slimly obese, thinly obese. You can say it as they are thin, but still they are obese because of the visceral adiposities. That is the fat accumulation in all the major organs. This is the one of the reasons for insulin resistance, and this is the one of the reasons for the early development of type 2 diabetes and cardiovascular disease. So this is a beautifully depicted slide. Says that metabolic changes in the Indian phenotype. You can see on the left hand side that the European phenotype, the A is the length and B is the lean mass, that is the metabolic capacity, and C is the volume of the fat mass. What you can see on the left hand side, you can see the European phenotype, and on the right hand side you can see the Indian phenotype. You can make out the difference that Indian phenotype, the volume of fat mass is more when compared to the European phenotype. So what happens over a period of time, this thin fat phenotype goes on increasing in Indians. The fat mass goes on accumulating, and the elevated ratio of load to capacity and ultimately leads to the development of diabetes. Central obesity and consequent inflammation drives insulin resistance in Indians. You can visceral adipose tissue is a seat of chronic low-grade inflammation. Chamarin, an adipokine, initiates the inflammation by recruiting plasmacytoid dendritic cells into the visceral adipose tissue. This induces the production of type 1 interferons, pro-inflammatory polarization of adipose resident macrophages, ultimately leading to adipose tissue and systemic insulin resistance, leading to more type 2 diabetes. So if you see the obesity phenotype, an interesting slide, you can see on the left hand side the normal weight, where the BMI is 18.5 to 25. You can see the fat mass is normal, lean mass is normal, cardiorespiratory fitness is also normal. The second person you can see is an athlete. His body mass index is more than 30. Fat mass is decreased, lean mass is increased, cardiorespiratory fitness is increased. Third one is non-sarcopenic obese. Body mass index is more than 30. Fat mass and lean mass is increased. and there is a cardiorespiratory fitness, there is a mild impairment. The last one, you see the sarcopenic obese, his fat mass is increased, lean mass is decreased, and cardiorespiratory fitness, there is a severe impairment. See the various phenotype of obesity which you are seeing in the picture. I'm sure you're wondering where majority of obese Indians will fall. We are the mixture of all of them. So not all obese patients are equal. So on the left hand side, you can see there is a metabolically healthy obesity defined by increased adiposity, body mass index, insulin sensitivity, and systemic inflammation will be neutral. Adipose tissue, there is distribution. There is an increased subcutaneous distribution of fat compared to intra-abdominal fat. And adipokines will be like decreased adiponectin, increased leptin, increased resistin, increased FGF21. On the right hand side, you can see metabolically unhealthy obesity is defined by increased obesity, adiposity, and body mass index, decreased insulin sensitivity, increased systemic inflammation, and metabolic syndrome will be present. Adipose distribution, there is an increased subcutaneous as well as intra-abdominal fat, which leads to increased epicardial fat, increased hepatic fat, increasing the skeletal muscle fat, increased pancreatic fat, wherever all the fat accumulation will be there. And then coming to the adipokines, there will be grossly decreased adiponectin, increased leptin, increased resistin, increased cytokine, and FGF21. This is all metabolically unhealthy obese patients. So this is a simple chart saying that inflammation contributes to insulin resistance, beta cell dysfunction on the onset of type 2 diabetes. You can see on the left hand side, whenever there is a high metabolic load, that is excess calorie intake, there goes to adipose tissue, there will be adipocyte hypertrophy, hyperplasia, dysfunction, adiposity inflammation leading on to insulin resistance, leading on to type 2 diabetes. On the right hand side, you can see what happens in pancreatic beta cells. There will be endothelial stress, oxidative stress, mitochondrial dysfunction, reduced insulin secretion, leading on to islet inflammation and dysfunction, leading on to insulin sufficiency and type 2 diabetes. This is how the pathophysiology of inflammation is contributed in the development of type 2 diabetes. Very simple chart, but very easy to understand. So this is how the metabolic stress acts on the beta cell and causes the secretory failure and apoptosis, leading on to interleukin 1 beta. Macrophages plays a role, and this is how the islet inflammation takes place in type 2 diabetes. Inflammation in macrovascular complications of diabetes. On the left hand side, you can see on the adiposity, adipocytes and vasculature, cytokines and chemokines. Ultimately, what will happen is leading on to pro-inflammatory and pro-atherogenic mediators, which will eventually lead on to insulin resistance and leading on to the development of atherosclerotic plaque. So inflammation in microvascular complication, once again, the hyperglycemia and hyperlipidemia leads to oxidative stress, leads to inflammatory signaling cascades, local activation of pro-inflammatory cytokines, leading on to inflammation, finally resulting in nephropathy, retinopathy, and neuropathy. So inflammation is the main thing to be considered in the development of microvascular as well as macrovascular complications of diabetes. What are the potential markers of the chronic low-grade inflammation? First one is the basic one, that is the WBC count, and serum cytokine markers, that is interleukin 6, TNF alpha, interleukin 10, acute phase reactants like HSCRP, amyloid A protein, fibrinogen, and CD8 plus T cells increased and decrease in the CD4 plus T cells. This is all the potential inflammatory low markers in the chronic low-grade inflammation. WBC count and HSCRP, which can be used in our day-to-day practice, is a basic and very simple to do it. There are various studies which says about the prospective evidence linking the inflammatory markers to the diabetes development. It may be starting from 2001 from Pradhan et al. There are so many studies which you can see in the chart where they have seen the inflammatory markers like CRP, interleukin 6, fibrinogen, white cell count, adiponectin, all have been implicated in the development of type 2 diabetes. So adiponectin, TNF alpha, and inflammatory cytokines and risk of diabetes. If you see the systemic review and meta-analysis, we can see that low levels of adiponectin is increased the risk of type 2 diabetes. So adipocytokine biomarkers are the predictors of type 2 diabetes and should probably may be measured to target therapy and intervention. Tomorrow, if somebody asks, Doctor, inflammation you are telling so much, is there any biomarkers you to say whether future I'll develop a diabetes or not? So at that point of time, you can definitely measure this interleukin level, adipocytokines, and all those things, and tell this is high. So you have to address this issue so that we can prevent the development of type 2 diabetes. So CRP is an independent predictor of risk factor for the development of diabetes in the West of Scotland coronary prevention study. You can see this IS quintile associated with more than threefold risk of developing diabetes. HSCRP and incidence of type 2 diabetes among patients without diabetes, increasing the tertiles of HSCRP at baseline associated with an increased risk of type 2 developing diabetes during a median follow-up of a period of 3.7 years. So this is a study which is depicting, if you see the mediators of inflammation in progression of normal to type 2 diabetes in Indians, you can see this on the left hand side, you can see the serum HSCRP. On the right hand side, you can see the interleukin 6. So both are elevated in hyperglycemia. So these are the important things to be considered, HSCRP and serum interleukin 6. So you see the HSCRP and the CV risk marker in diabetes. On the left hand side, you can see that both of them are increased, and that will have a predictor of development of cardiovascular events. So many studies have been done using the HSCRP as an biomarker. So HSCRP, CV risk factor with or without metabolic syndrome. This is also based on the Women's Health Study and the West of Scotland coronary prevention study. You can see that how the HSCRP plays an important role in the development of metabolic syndrome as well as type 2 diabetes. Associations between the basic indicators of inflammation and the metabolic disturbances, you can see here, higher the HSCRP, higher the risk of development of type 2 diabetes as well as cardiovascular disease. And another one, high blood cell count is associated with a worsening of insulin sensitivity and predicts the development of type 2 diabetes. This is the study published in 2002. So since nearly 20 years or 25 years, this concept is going on about the inflammation and diabetes. So baseline WBC count more than 6,900 had an independent 52% risk in diabetes risk versus the lowest quintile, that is the WBC count of 5,000, less than 5,400. Associated between the basic indicators of inflammation and metabolic disturbances, you can see WBC count more than 9,000 have an higher risk of developing developing type 2 diabetes. These are the three things you can see relationship between the WBC, CRP, the metabolic syndrome, being both a Caucasian and the African Americans, which has showed that the concept of metabolic syndrome is high in these patients and ultimately leading on to the development of type 2 diabetes. Adiponectin and progression to diabetes in the DPP, that is the diabetes prevention program. You can see if baseline adiponectin level are higher, progression to type 2 diabetes is slower. So that is the importance of adiponectin. Another perspective studies in diabetes, it shows neutralizing TNF alpha at the earlier stages improves the insulin sensitivity. See this study, which was published way back in 1994. That means the concept of inflammation and diabetes is going on since 1994. So, type 2 diabetes, an inflammatory disease leading to insulin resistance and beta cell function. These are the international evidence starting from in 2001 in JAMA. You can see the CRP, interleukin 6, and risk of developing type 2 diabetes. In 2004 also, there was a link between insulin resistance, obesity, and diabetes. 2011, type 2 diabetes as an inflammatory disease, published in Nature's. In 2013, a chronic inflammation role in the obesity diabetes association, a case cohort study. So various studies has been done to show an inflammatory link to the type 2 diabetes. Ladies and gentlemen, to conclude my talk, prevalence of type 2 diabetes is rising in India. Markers of systemic inflammation has been critically implicated in the pathogenesis and complications of type 2 diabetes. Abundant clinical evidence explains role of systemic inflammation in obesity, metabolic syndrome, insulin resistance, and beta cell function. Thank you for your patience hearing. Over to Dr. Unni and Dr. Faraz. To the end of the session, we can have a good discussion.
Thank you very much, sir, for the excellent presentation. Sabir, we will go to the next topic or we will take questions now?
So then we will have the discussion at the end. We anyway, congrats Dr. Aravinda for that excellent lecture. Next topic is something regarding inflammation again. The topic is the role of hydroxychloroquine in diabetes management in the present scenario. For this, we have a guest speaker. He is my very close friend, Dr. Farishta. He is the professor, Medicity Institute of Medical Sciences, and also the director of FS Endocrinology Diabetes Center. He is also the senior consultant endocrinologist, Tumbe Hospital. He is a principal investigator for various global trials, and he has been awarded the prestigious Abdul Kalam Memorial Award in the field of endocrinology. He has more than 50 national and international publications. He has articles in more than 50 national and international indexed journals, and he is also the speaker for various national and international forums. Over to you, Dr. Faraz.
Yeah, so thank you so much for inviting me for this academic feast, and then thank you, Arvind, for rolling on the dice. To continue it from there, as my friend was talking about inflammation, I think in this corona epidemic, one thing which everybody wanted to speak about is about their opinion. You would agree, right? From a layman to the politicians, everybody has tried to share their opinion. And I'm so thankful that we did not follow this gentleman's advice of injecting something for treating the pandemic. So this is how things are rolling out in this pandemic on the lighter side. So I think HCQ is now crossed lot number of geographies. You will see now it's being used across the globe, at least for the pandemic what we are having. So definitely it is wise to know about the history as well. So first time US FDA approved way back in 1950s for predominant use in rheumatoid arthritis and lupus. 2001 it was endorsed to used in rheumatoid arthritis. 2006 for polymorphic light eruptions. 2008 for lupus erythematosus, and 2014 is where the Central Drug Standard Control Organization in India gave it a clean go for usage in diabetes. So in 28 July, DCGI approved for the first time use of HCQ in type 2 diabetes. It said that HCQ can be used as an adjunct to diet and exercise to improve glycemic control of patients who are not controlled on metformin and sulfonylurea combination. So there are different various mechanisms of action of HCQ. Still, I would not say I would place my hand on any of the four, but there are different mechanisms which are being postulated. So out of the four, that inhibition of insulin degradation, reduction in inflammation, improves insulin sensitivity, and beta cell preservation. So we'll see one by one. So inhibition of insulin degradation. We all know that insulin degradation pathway half-life of insulin is 4 to 6 minutes, and then it gets degraded by the insulin degrading enzymes in the acidic environment. So how does HCQ, what does HCQ does? So HCQ, it insulin binds to a receptor on the cell membrane. We have seen that there is internalization of the receptor insulin complex in the vesicle. Then the insulin dissociates from its receptor. This is where again HCQ is trying to act. And it is also acting at the acidic environment. So HCQ is causing alkalization, results in inactivation of the IDs, which lead to less insulin degradation, so that insulin is released as it is and ready to act again. So this is one pathophysiology which is behind the action of HCQ on reducing diabetes. And then this is an interesting paper which says that HCQ increases insulin levels. There is definitely preclinical evidence. So as blood HCQ concentration increases, the insulin degradation decreases and blood insulin level rises. This is seen as early as after 10 days of therapy. Coming to the inflammation, I think my fellow colleague has spoken already a lot on inflammation and role of CRP. So this is one drug which is definitely has shown that it reduces hsCRP by more than 1 when correlating with reduction with the A1C. So it is not only helping to reduce the hsCRP, but it is also correlating to the reduction in A1C, which can be seen in the range of 0.7 to 1.3. In patients who were treated with insulin, glimepiride, and metformin on whom the HCQ was added. It improves the insulin sensitivity. So this is again very, very important. I think it is clearly showing that it has anti-diabetogenic effects on insulin sensitivity and beta cell function. So HCQ improves the beta cell function and insulin sensitivity in non-diabetic patients. So this was a random double-blind non-diabetic overweight patients who had impaired fasting glucose between 100 to 126. They were started on 400 milligram on one arm versus placebo on another arm for a period of 13 weeks. So this results have shown that HCQ improves both the beta cell function and insulin sensitivity in the pre-diabetic individuals as well. The metabolic effects may explain why HCQ is associated with lower risk of type 2 diabetes. So that there was a conclusion that HCQ increases the plasma adiponectin levels, and we all know adiponectin levels is higher in females when you compare it with the males. It is lower in diabetic patients when you compare it with the non-diabetic patients. And adiponectin is definitely the higher the level of adiponectin, the lower amount of insulin resistance you will have. So this is one drug which has shown that HCQ improves the adiponectin level, possibly being a mediator of favorable effect on glucose metabolism. HCQ improves the insulin sensitivity in obese non-diabetic individuals. So this is a clinical pharmacodynamic study where HCQ increases the insulin sensitivity during the first 6 weeks. So you will see on the left side of the graph, the first 6 weeks, the insulin sensitivity when the patient was on HCQ raised from 4.5 to 8.9. And then there was a dip when HCQ was stopped. Similarly, HCQ decreased the insulin resistance. So when HCQ was started, the insulin resistance dipped from 2.1 to 1.8 in 6 weeks. And again, it took a peak when HCQ was stopped. So this is a study which was done in rat to see the HCQ hindering of diabetic idiopathy, and then it carries its signature on the inflammatory cytokines. So 45 rats were divided equally into two groups, one with diabetes and one with HCQ on diabetes. So the rats who were on HCQ and diabetes, these groups showed preservation of islet of Langerhans structure, slight increase in the beta cell mass, and then IOL proliferation and neogenesis. And then it has definitely shown to reduce the amount of inflammation. I think this is where we all would agree. That is why the role of HCQ came drastically in treating the present pandemic of COVID, because there is definitely some amount of inflammation reduction which is happening with this drug, because all of us know that yes, COVID is also now a inflammatory disease. So just to correlate it with diabetes, what my friend was saying, diabetes, one of the pathophysiological mechanisms, yes, we have moved on from 8 to Arrhenius 11 and to the dirty dozen 12. We will move till there. So there is definitely a role of HCQ in reduction in the inflammatory parameters as well. So it has a lot number of international studies, Indian studies, observational studies, and case reports. I'll be talking only about the few of them. So this is a study which was published in JAMA in 2007, where probability of developing diabetes in rheumatoid arthritis patients with HCQ use was seen. So this is a prospective multi-center observational study of 4,000 odd patients with rheumatoid arthritis who had taken HCQ and 3,900 odd patients who had never taken HCQ. And there was no diagnosis or treatment of diabetes in outpatient university-based and community-based rheumatology practices with 21.5 years of follow-up. So that's a huge follow-up. So use of HCQ for more than 4 years was associated with 77% lower risk of developing diabetes in patients who were on HCQ who had rheumatoid arthritis when you compare it with their other colleagues. This is an international study in 2018. This is a randomized double-blind placebo-controlled trial of HCQ versus placebo. The patients who were included in the study had A1C of more than 8, were having obesity, diabetes for more than 1 year, were on metformin 1.5 grams and glimepiride inadequately controlled. So the third line of agent, HCQ 400 once daily, was added in one arm compared to placebo, which was added in another arm for 24 weeks. So there was a significant improvement. You would see the graphs there, not only in the fasting, which was reduced by 60, postprandial, which was reduced by 135 milligrams, and A1C by 1.3% when you compare it with the placebo. So definitely there was a drastic reduction in fasting, postprandial, and A1C when HCQ was added as the third line agent when patients were not getting control on metformin and sulfonylurea. This is a head-to-head comparison study of HCQ versus pioglitazone as third line of agent. So here again, patients who were inadequately controlled had an A1C of 7.5 to 11 with metformin and sulfonylurea were taken into the study. One arm HCQ was started, another arm pioglitazone was started. So again, this also endorses on the point that HCQ may be beneficial in uncontrolled type 2 diabetic patients as a third line agent. This is the first Indian clinical trial, the efficacy and safety of HCQ in treatment of type 2 diabetes. A blinded randomized compare again with pioglitazone. So 806 patients were assessed for eligibility. They were type 2 diabetic patients, again uncontrolled on two drug combination therapy, metformin with glimepiride or metformin with gliclazide at their maximum doses. A1C of between 7.5 to 13%. Out of which total patients in the run-in period were around 493, out of which 267 patients were randomized, one arm on HCQ and one arm on pioglitazone. So there is hardly anything to choose when you see the results at baseline and at 24 weeks. So you'll see at 24 weeks, the fasting blood sugar reduction with HCQ was 19.87 milligrams when you compare with pioglitazone, which was around 20. Similarly, you will see this results in postprandial, and A1C reduction with HCQ was 0.87% when you compare it with the pioglitazone arm, which was around 0.9%. So there was definitely indication that this is non-inferior as a third line drug when you add instead of pioglitazone. So HCQ in type 2 diabetes observational studies where around 49 patients were included in this study. Again, type 2 diabetic patients on combination of two oral hypoglycemic agents, metformin and sulfonylureas, not getting controlled, A1C of more than 7.5%, were started on HCQ 400 milligrams once daily for 24 weeks. So the interesting part is none of the patients discontinued the drug during the course of treatment owing to these side effects. I think this is also helping us and telling us that yes, the only side effect which we have already seen with this drug is some amount of nausea or some abdominal discomfort, which we have seen usage of chloroquine or hydroxychloroquine way years and years when we have treated patients with malaria with these drugs. So to come to my last slide of my presentation, HCQ in type 2 diabetes observational studies. This is a real life effectiveness and tolerability of HCQ in diabetes. So definitely this is one drug which is not only helping us to reduce the sugars, but it has definitely shown some reduction in metabolic parameters like lipid profile has shown reduction in LDL also. And then the patient did not have any side effects because of which they had discontinued the therapy. So just to end it on a lighter note, I think all of us sitting here have seen Sholay, or all of us have heard stories about Sholay from our parents, from our grandparents. If Sholay would have been remade in 2020, if I think my senior colleagues who are sitting here would remember the famous line where mother used to say to the children, "So ja, varna gabbar aa jayega." I think if it was to be remade, it would have been changed to, "जब बच्चा बाहर से आता है, तब माँ कहती है, हाथ धो लो वरना कोरोना वायरस आ जाएगा." So be safe, and stay healthy. Thank you so much.
Thank you, Dr. Faraz, for that wonderful lecture. Thank you, Dr. Faraz. I think, and a special thanks to keep time also. So we will have the discussion at the end. So I think, Sibi sir, you can continue.
Now we will go on to the next topic, real world evidence of role of hydroxychloroquine in diabetes mellitus. I am privileged to introduce Dr. A G Unnikrishnan. If I go on to narrate the credentials of Unnikrishnan, it will take all the time for this entire CME. So I will just introduce him. He is a senior consultant endocrinologist and CEO of Chellaram Institute of Diabetes, Pune, which is an IDF certified center. Has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide. He is a former editor-in-chief and founder editor of the Journal of Thyroid Research and Practice. He is the executive editor of Indian Journal of Endocrinology and Metabolism. He has more than 160 publications in Indian index journals in favor of his credits. He has received the Subhash Mukherjee Ovation Award for the Endocrine Society of India. Also received the Srivastava Award from the RSSDA. He is an awardee of Jacob Memorial Prize for the Best Patient Care awarded by the CMC Vellore. He is a fellow of the RSSDA, and he also received recently the Diabetes Excellence Award at Digital Diabetes Summit at Hyderabad in 2019. Over to you, sir.
A pleasure being here. Thank you, Dr. Rasheed, for a wonderful meeting. And thank you, Dr. Sibi, for the kind introduction. Thank you. And I'm going to talk about hydroxychloroquine in the real world. And let me begin with a. Now, this is a 56-year-old lady with type 2 diabetes since 2011. She also has rheumatoid arthritis. And she had been on Ayurvedic treatment for rheumatoid arthritis. Initially, when we saw her, her fasting glucose and postprandial glucose were high and the glimepiride dose was increased. Finally, the sugar wasn't coming down, and because of the rheumatoid arthritis also, I added hydroxychloroquine to the regimen. So as you can see, she was on glimepiride, sitagliptin, metformin, to which I added hydroxychloroquine. This was long time back in 2017, where my initial experience of hydroxychloroquine was with rheumatoid arthritis patients with diabetes. And then, after 24 days, the fasting the blood glucose came down from 172 to 135, and the postprandial came down from 201 to 191. And she said that she felt much better in terms of her joint pains. Into perspective, because I'm going to talk about the real world experience with hydroxychloroquine. This is a prospective investigator driven study. So I'm looking at cases and then I'm pulling out some data which backs the use of these cases in practice. So this is a real world study of type 2 diabetes, an observational study which looked at 250 subjects with diabetes more than 5 years. Now you can see the people in this study were already on metformin, taking glimepiride, were taking pioglitazone and sitagliptin. 100% of these people taking all these drugs: metformin, glimepiride, pioglitazone, sitagliptin. A small proportion were taking canagliflozin, empagliflozin, dapagliflozin, and voglibus. So in this group of patients, probably these patients were not keen on insulin. So the authors gave hydroxychloroquine, and you can see the HbA1c came down from 8.8 to 6.4. The fasting plasma glucose used by 58%. And this is another real-world study which showed that in a small number, the LDL reduced and the fasting plasma glucose reduced. One of the worries about hydroxychloroquine is its effect on the retina, and I must disclose that I am an investigator for trials and present trials and upcoming trials on hydroxychloroquine. So this is one of our with hydroxychloroquine. Patient was started on linagliptin, glimepiride, metformin. Patient was on amlodipine and lisinopril, and in May 2019, hydroxychloroquine was added. It's important that you can see that with hydroxychloroquine, 70 years old, 4% to 6.1%. But it's very important that these people actually be screened for retinopathy. And in people on retinopathy, hydroxychloroquine ideally should not be given, though the trial is in progress. But I think the worries of retinopathy with hydroxychloroquine are largely exaggerated, because while yes, it can cause retinopathy, the risk of retinopathy is only with very high doses given for a prolonged period of may not make a difference, but you still have to do annual screening, and you can see the annual screening. As part of the annual screening, optical coherence tomography was done for this patient, which shows that everything was okay. So again, to tell you, this is a study of the safety and effectiveness of hydroxychloroquine in management of people with type 2 diabetes. I just add that these slides have been made by me, and this assess the real life safety and efficacy of hydroxychloroquine in 95 subjects. These subjects had hydroxychloroquine started, and then they were assessed again. The diabetes duration was 9 years, and statins and antihypertensives were used. This data was just published as an abstract, and you see the data. This was by Chawla et al. In Diabetes 2020 at the American Diabetes Association. You can see that within just a short period of time, at 3 months, the HbA1c came down from 8.8 to 8%, and subsequently at the end of 6 months, it came down to 7.7%. The fasting plasma glucose was 185, came down to 150. Postprandial was 228, came down to 188. Of course, no safety signals were seen in the study, and you can see the lipid profile also improved. So here is a study which compares hydroxychloroquine versus teneligliptin, and this is a 6-month study, and you can see that from baseline hydroxy in terms of fasting 173 and 171, and at 6 months these values come down to 128 and 132. Again, the postprandial was 268, 266, and that came down to 190 and 190. So this study shows that in terms of glucose control. Here is another study where hydroxychloroquine was added uh, click, and you can see fasting coming down well. This was again a study of 105 type 2 diabetes patients, age 56 years, BMI 2600 people completed the study. People were on already high dose gliclazide of 80, not very high dose, but high dose, and metformin 1000 milligrams, and glargine at or more than or equal to 30 units, coming down to 6.69 at the end of 6 months. And you can see the postprandial coming down in the orange color, the fasting coming down in the blue color. And this study shows that hydroxychloroquine works in a background of insulin, sulfonylurea, and metformin. This is another gentleman, and you can see that he was taking sitagliptin, metformin, lispromix, dapagliflozin, and hydroxychloroquine. He did not wish to take a basal bolus insulin therapy. What we found in this gentleman who had a AGP done is that his estimated A1C was 5.8%. This is also now called a glucose monitoring indicator. His glucose was 121, so very good control. You can even see the time in target was 72%, below target was 21%. The recommended time in target is 70%, so that's in range. But you can see this patient has significant hypoglycemia, and hypoglycemia is probably because of insulin. And in this patient, ideally, insulin could be reduced or even stopped in some of these patients. But just to show you that sometimes we have to individualize our practice and use the best treatment that is needed. And in this gentleman, a group of all these drugs were able to control the blood glucose levels. So I'd like to just summarize some of these observational studies. So you can see that if you just there are studies which compare teneligliptin, vildagliptin, and sitagliptin, and all these studies show there is a good HbA1c reduction with hydroxychloroquine, but in addition, there is a CRP reduction in the hydroxychloroquine group. But it all reported that if you look at metformin and sulfonylurea and compare it, supposing your patient is on metformin and SU, or you add hydroxychloroquine, you will get a similar result. So mean hydroxychloroquine HbA1c was 6.5 in the hydroxychloroquine group versus 6.8% in the metformin group and 6.7% in the uptitrated glimepiride group. So if your patient is on a median dose of glimepiride and metformin, you have two options. One is you can increase the dose of glimepiride metformin. Second is you can add hydroxychloroquine. So adding hydroxychloroquine in this study showed a good effect on the HbA1c. And another study which looked at very interesting 200 versus 400 dose, and this study showed that 400 was better than 200 dose. The HbA1c reduction, fasting plasma glucose, postprandial plasma glucose were all better in the 400 dose compared to the 200 dose. Also, there are studies which show that hydroxychloroquine may be as good as teneligliptin or sitagliptin. If you want to summarize these other two studies, which looked at hydroxychloroquine as an add-on to metformin, SU, and basal insulin, what it showed is that the fasting, postprandial, and HbA1c all improved with hydroxychloroquine. Insulin glargine dose came down by, where we gave a gliptin and SGLT2, metformin and lispromix, and when hydroxychloroquine was added, you can see the HbA1c coming down, and this means that insulin can actually be reduced. In 41%, the authors report that insulin glargine could be completely stopped. In 12%, they could reduce gliclazide to 40 mg. And of course, this study by Dr. Charles was presented by Dr. Farishta as well. And this was an abstract presented at the American Diabetes Association meeting, which showed that postprandial and HbA1c reduced by 18% and 0.8%, and there was a lipid benefit. Hydroxychloroquine is a promising third-line anti-diabetic drug in patients with type 2 diabetes who are uncontrolled on metformin MSU. Better glycemic control as compared to DPP-4 inhibitors was shown in some studies, but we can accept that glycemic control could be similar with hydroxychloroquine. There is some evidence of a beneficial effect in high insulin users because hydroxychloroquine may help to decrease the daily insulin dose. Hydroxychloroquine in clinical practice isn't associated with glycemia, and decrease in highly HSCRP, which is shown to be the main culprit in inflammation, was noted in hydroxychloroquine patients. So thank you all for listening to me. Thank you, Dr. Sabir, for a fully organized meeting, and it's back to the chairperson for the discussion.
Sibi sir, please. Sibi sir and okay.
Hello. Am I audible?
Yes, sir, please.
Thank you, sir, for the nice presentation on the real-world evidence of SCQS in type 2 diabetes. Now we will take questions. Okay, Shabir? There are some questions in chat box.
Yes, sir. One question is there.
One Dr. Tyagarajan Arimugam wants to know what is the dosage of hydroxychloroquine and criteria for starting hydroxychloroquine in type 2 diabetes.
Would you like me to take that question?
Yeah, you can take, sir.
Thank you. And so therefore, hydroxychloroquine for diabetes, the Indian government has approved it for the 400 milligram dose. And what they have recommended is that it is an adjunct to treatment with metformin and sulfonylurea. So anybody on 2 oral drugs who are not getting a control of HbA1c, hydroxychloroquine could be considered. The only exception is it should be used in type 2 diabetes, and also it is better not to use the drug in people with pre-existing in people who fail type 2 diabetes, failing 2 drugs, having high HbA1c without retinopathy. That's where I think hydroxychloroquine at the dose of 400 milligram once a day can be used, and you can use it for a prolonged period of time, up to 3 or 4 years. As your patient is not very thin, if below 50 mg, 400 mg will be a slightly higher dose. So as long as the patient is above 50 or 60 mg, the 400 mg dose should be quite good enough.
Thank you, sir. There is another question from Dr. Ajit Kumar Shetty. What about the patients with cardiac diseases and diabetes? Is there any increased risk of starting hydroxychloroquine with concerns of QT interval prolongation? And this is more important in the current situation of corona pandemic.
So hydroxychloroquine, maybe Dr. Farishta and Dr. Jagadeesha should also take this question. Has in rheumatoid arthritis trials, there have been large trials that actually showed that hydroxychloroquine reduces cardiovascular events. But indeed, if patient is already having a history of arrhythmia, or there is a predisposition to arrhythmia, or is using drugs capable of producing arrhythmia, then you need to be careful. But otherwise, hydroxychloroquine, you don't have to worry about this situation. But with regard to the COVID pandemic, and maybe my colleagues, Dr. Aravinda and Dr. Farishta, could also opine on this.
So my opinion is like, especially if the patient is above 60 plus with the previous history of cardiovascular disease, if anything is there, always, if at all you plan to start hydroxychloroquine, it's better to take a simple ECG and just measure the QT interval, and accordingly you can plan. Otherwise, if you see the hydroxychloroquine various study, it has a beneficial role to play in cardiovascular outcome also. So because it's an anti-inflammatory, there are various studies to show that in a long run, if the patient is taking hydroxychloroquine, it can prevent the cardiovascular morbidity and mortality. So, but always it is better to get on, because in an young patient definitely it's not a problem, because we are using as hydroxychloroquine used in various conditions like rheumatoid arthritis, is maybe SLE, yes, many condition, and people are taking since many years without any problem. So as Dr. Uni pointed out, always make sure that two drugs when they're using, for example, hydroxychloroquine and azithromycin, when they're used together, always monitor the QT interval. Faraz, any opinion yours?
I think I would agree with my senior colleague Dr. Uni and Aravinda on the same that yes, baseline ECG is always required if we are starting it in senior elderly patients with pre-existing cardiovascular disease. And then yes, it is very just to be on the safer side if we are starting in elderly individuals, as my friend said, azithromycin, sometimes even cimetidine, of course, we are not using it now, but even quinolones are also prone for prolonging the QT intervals. So just to see if the other drugs, arrhythmogenic drugs, which can aggravate the effect of HCQ in pre-existing diabetic cardiovascular patient.
One important other thing is the role of hydroxychloroquine. If you take in this current situation, what I am seeing is in a diabetic patients who are already on hydroxychloroquine as a third line or a fourth line agent, we are seeing less number of COVID virus infection. It's an totally, it may be long-term study is needed, but what in my clinical practice, in a day-to-day practice, those who are already on hydroxychloroquine for diabetes, there are less chances of coronavirus. And this is what the ICMR is also telling, to use hydroxychloroquine in a selected, in all patients, in fact. So many are agreeing, and even the Lancet publishers also, what yeah, they had published about the few bad things about hydroxychloroquine. Now they have reverted and they are telling that hydroxychloroquine is a better drug.
I think I would definitely agree on the same because ICMR is now even indicated for doctors for pre-exposure prophylaxis as well. So they are recommending doctors to take it for healthcare professionals who are on the high risk of exposure. I think we all know the dose 800 milligram loading for it by 400 milligram. First they said weekly once for 7 weeks, and now they say you can take it for longer period of time. So definitely, I would agree with my friend on my clinical experience as well. I would share my clinical experience with the healthcare professionals which have been taking my colleagues, my juniors, which have been taking. So that definitely there's been lesser incidents in healthcare professionals also who were on HCQ, and even if they had developed the symptoms, it was just very, very mild. None of them had that moderate or severe symptoms.
And hydroxychloroquine for retinopathy or something, the cumulative dosage is huge. Like it may be like 1 kg. I'm sure Dr. Unni will agree about this. In a overall duration of hydroxychloroquine intake, if the cumulative dosage is more than 1 kg or so, then the chances of retinopathy is there. So 400 milligram once a day is in a long term also, even after 5 years, 6 years, it should not be a big concern.
Agree.
Okay. Thank you, all the speakers, Dr. Aravinda, Dr. Faraz, and Dr. Unnikrishnan, for the excellent presentations and nice discussion. For want of time, there are lots of questions, but for want of time, we will conclude. We should conclude at this moment. And I should thank Dr. Sabir for the wonderful opportunity, and thanks Sabir and all the team. Thank you very much.
Thank you.
Thank you very much.
Thanks to all the three respected faculties for the wonderful lecture. Thank you, Sabir, also. Now moving on to the next session. Thank you.